Greetings. This is Russ Fawcett, President of the North Carolina Friends of Midwives, and I have put this assessment together to address some gross mistruths in the claims made by the North Carolina Medical Society to the Child Fatality Task Force and the legislators in the General Assembly. To begin with, this is not a happy story, but one that needs to be told, and so I don't want to sound disingenuous in thanking the Perinatal Health Committee. Nevertheless, I feel it is important to do so as the members and leaders have been very welcoming of our engagement and our issue can be a little disruptive. So I thank the committee for being very inclusive of us as we work through our home birth issue. Simply put, the leaders of the North Carolina Medical Society have been dishonest with the Child Fatality Task Force, they have been dishonest with the members of the General Assembly, and they have been dishonest with their own physician members. They have claimed that in 2012 there were 11 neonatal deaths at 300 home births in North Carolina attended by certified professional midwives. This accusation is a factor of 5 to a factor of 20 incorrect and reflects the most sophomoric and unprofessional behavior as can be offered from such a substantial organization with the sole purpose of hurting North Carolina families who don't have to ask their permission to choose midwifery care in the home setting for birth. In the next 20 minutes, I will provide some context, including the unfortunate antagonism that exists between the medical society and the women who favor midwifery care in the home setting for birth. I will discuss outcomes and safety analysis, and I will discuss the claims made by the Medical Society and contrast it with the truth. If we look regionally and across the United States, we see a spectrum of environments for midwife-attended planned home birth, from best-in-class states such as Tennessee, Virginia, and the state of Washington, where certified professional midwives are licensed, to poor states such as Illinois. A state can be evaluated by considering attributes such as access to trained and credentialed home birth midwives, the relationship between the midwives and the hospital community, reimbursement, and a variety of other factors, including how the state's licensing framework affects a mother's right of sovereignty and autonomy in her childbirth decisions. A few years ago, I would have evaluated our state as a state in transition with a positive trend. There was a healthy population of certified professional midwives serving North Carolina families, and rates of midwife-attended planned home birth were accelerating in a noteworthy way. There had not been a criminal prosecution of a home birth midwife since the 1990s. The consumer advocacy organization, the North Carolina Friends of Midwives, was fully engaged with the legislators with broad support. And North Carolina was, and is, surrounded by states that license certified professional midwives. In the past several years, our state has devolved into the most hostile state in the United States for this growing population of families. There have been several criminal prosecutions against certified professional midwives who can work legally in all of our neighbor states, along with numerous cease and desist orders that tend not to be publicized. I will point out that disenfranchising the primary care provider for these families does not improve safety and is not honorable. We believe the current hostile status is a direct result of the Medical Society's prejudice against the home setting for birth and their considerable influence. When we see what CPM attended home birth outcomes truly are in later charts, and compare with the outrageous claims made by the North Carolina Medical Society, I think most will agree. On November 14, 2012, Dr. Haywood Brown, president of our state's OBGYN Society, told the Perinatal Health Committee of the North Carolina Child Fatality Task Force that there had been 11 bad outcomes in the past year. Subsequent to this, during the long legislative session, as Senate Bills 106 and 107 were gaining momentum, the North Carolina Medical Society released this letter to members of the North Carolina Senate. Aside from the disdainful language, they again claimed that there had been 11 neonatal deaths out of 300 home births in the previous 12 months attended by certified professional midwives. This accusation has no basis in reality, as we will soon see, and it is difficult to believe that this was an honest mistake in light of their behavior. In discussing safety and safety analysis, I will begin by saying that families working through birth injury or loss are not numbers, and as we consider safety and its convergence with policy, we should not lose sight of how deeply personal these matters are to the affected families. Considering safety in general terms, our community views the childbearing year and the birth event as a normal life process with safety significance, and the mothers have ultimate sovereignty on the planned place for birth and the attendance. Indeed, these are truisms. Another way to view safety is to recognize that there are all kinds of bad things that can and do happen during pregnancy and childbirth, ranging from maternal mortality to a neonatal demise, to a peripartum hysterectomy, to postpartum depression and psychosis. Indeed, this is also true. While it makes sense to invest much of the attention on perinatal mortality, given the severe impact on the family, coupled with the frequency of occurrence, this falls short of a comprehensive safety analysis without due consideration of outcomes for the mother and her future children. Indeed, a comprehensive analysis of safety would find many safety benefits for midwife-attended planned home birth. Nevertheless, this discussion is to set the record straight with regard to neonatal outcomes for planned home birth in our state attended by certified professional midwives. To begin with, we should establish a frame of reference. The best reference to judge North Carolina's performance with respect to home birth outcomes is Johnson and Davis's large prospective study in North America that was published in the British Medical Journal in 2005. Two of the key strengths of this study were the prospective data collection and the compulsory participation, as it was a condition of certification for every certified professional midwife to provide their data. In any event, this study compiled CPM-attended home birth outcomes from all CPMs in North America in the calendar year of 2000 and is sometimes referred to as the CPM 2000 study. As mentioned earlier, there is a spectrum of environments for midwife-attended planned home birth, and these results include all U.S. states, ranging from states where certified professional midwives are licensed to states in which they are practicing in violation of the Medical Practice Act. There is one more aspect to discuss before reviewing the findings of the CPM 2000 study related to the time period of interest. On the chart, you see the perinatal period that is frequently defined as beginning at 20 weeks gestation and ending at 28 days postpartum. There are other definitions used, but this definition is consistent with this discussion. The perinatal period has been partitioned into the fetal period that extends from 20 weeks gestation through birth, and the neonatal period that begins with the birth of a live baby and concludes at 28 days postpartum. The intrapartum period is the period of time from the onset of labor until the completion of the third stage of labor when the placenta is born. Our interest is in the influence of the setting and the attendant on outcomes, and therefore the intrapartum and neonatal periods are of primary importance in the period that Johnson and Davis studied. To summarize, there were 5,418 planned home births at the onset of labor during the study period, and the intrapartum mortalities in addition to the neonatal mortalities were collected. There were a total of 18 perinatal mortalities that are summarized on the chart. The home setting had no influence on the 4 fetal deaths that occurred prior to labor and are not considered further. There were 5 intrapartum deaths or stillbirths, and 2 of those were associated with breech presentation. Note that there were 80 planned home births with breech presentation during the study period and 2 bad outcomes. Breech presentation is considered controversial and should be evaluated separately. There were 9 neonatal deaths during the study period, 3 of which were attributed to lethal congenital anomalies. The aggregate intrapartum plus neonatal mortality rate was 2.6 per 1,000 live births, and excluding the congenital anomalies and breech presentation, the rate becomes 1.7 per 1,000 live births. I invite you to review the paper, and if you do, you will find that several of the adverse outcomes can be assigned to the hospital setting as they occurred after transfer. Nevertheless, they are maintained as planned home birth bad outcomes. We asked the North Carolina Midwives Alliance to collect and provide fundamental data for the calendar years of 2011 and 2012 to assure we encompass the period of time stated in the claims from the Medical Society. Note that the North Carolina Midwives Alliance is a statewide professional organization for certified professional midwives in the state. There were between 30 and 35 certified professional midwives resident in the state during this time period. However, only 14 had active practices due to the current unfavorable environment. 13 of the 14 practicing midwives reported their total number of clients expecting to deliver during 2011 and 2012, transfers, and outcomes. One midwife only reported that she had no adverse outcomes, such that the mortality rate is slightly overstated. In other words, the total number of planned home births attended by CPMs is higher than reported, and the number of adverse outcomes is unaffected. So, during the calendar years spanning 2011 and 2012, there were 573 planned home births in North Carolina in which the planned attendant was a certified professional midwife. This number should be viewed as somewhat low considering national and regional trends, and we view this low rate as a reflection of the poor environment. Of these 573 planned home births, 25 left care during the prenatal period for a variety of reasons. The number of planned home births attended by certified professional midwives at the onset of labor was then 548. Of these 548 planned home births, there were 38 intrapartum and postpartum transfers to the hospital. It is interesting to look at these transfers to the hospital. In one example, the mother experienced some bleeding during labor that the midwife judged as not normal and EMS was called. The midwife was concerned that birth was imminent and suspected excessive postpartum bleeding was likely and asked if the transporting medics carried anti-hemorrhagic medicine for postpartum bleeding. They responded that they did not, and the midwife insisted she transport with the mother. Birth occurred en route, and the midwife confidently administered the appropriate medicine to address bleeding as she is trained to do. We are very thankful that the midwife did not face prosecution for doing a good job. In another example, as part of the standard newborn examination following a planned home birth, the attending midwife detected an irregular heartbeat in an otherwise vibrant baby and advised transfer to the hospital for further assessment. It was determined that the baby had a potentially lethal congenital anomaly requiring surgical intervention. The attending pediatrician praised the midwife for her careful assessment that could easily be dismissed. Turning our attention to outcomes, there was one neonatal death in this population of over 540 singleton, which means one baby, vertex, which means the head is down, planned home birth, which is usually considered the home birth population. In this birth, the midwife advised transfer to the hospital during labor due to non-reassuring fetal heart tones. After arriving at the hospital, the staff did not judge immediate action, such as emergency cesarean section, was indicated, and the mother continued to labor. The baby was born with severe injury and later died. This kind of event can and does happen in planned hospital birth. In light of the fact that the midwife advised transfer and the receiving hospital did not judge emergency action was required, there is no indication that the standards of care were not maintained, nor that the home setting contributed to the outcome. So, one neonatal death in over 540 planned certified professional midwife attended home births during the calendar years of 2011 and 2012, which should not be considered different from the results of the CPM 2000 study discussed previously due to the small sample size. If viewed as a neonatal mortality rate, this result is a factor of 20 lower than the 11 in 300 claimed by the North Carolina Medical Society. As with the CPM 2000 study, in evaluating the safety of the setting for birth and attendant, it is appropriate to also examine the intrapartum mortality rate, which is the number of stillbirths, when the baby was alive at the onset of labor. During this evaluation period, there was one intrapartum demise. In this event, fetal distress was detected by the midwife, as she is trained to do, and the decision was made to transport. I'm sad to report that the mother and midwife were turned away from the first hospital that was identified in the emergency transport plan, and this is just one example of how safety is degraded in the current environment in which certified professional midwives are not licensed. In any event, at the second hospital at which the mother was received, the baby was born still as a result of a broken cord, and this complication likely occurred at home. This is an example of a true, time-critical obstetric emergency that is not predictable. These events also occur in planned hospital birth and frequently conclude in death of the baby. To put this in perspective, it would be necessary to know the frequency at which a broken cord of this severity results in a bad outcome in all settings of interest, including the hospital. Combining this intrapartum demise with the neonatal demise discussed earlier, in this population of over 540 CPM-attended singleton vertex planned home births, we see a combined mortality rate of approximately 3.6 per 1,000 live births, which is 1/10 that claimed by the North Carolina Medical Society in their lobbying efforts. While this value is higher than that observed in the CPM 2000 study, it is difficult to judge based on the sample size. For completeness, there was one congenital anomaly incompatible with life and one demise associated with breech presentation during this time period. As noted earlier, breech presentation is considered controversial for planned home birth. Indeed, breech presentation can be considered controversial irrespective of the planned place for birth and should be evaluated separately. In summary, there were a total of 4 mortalities in the entire population of CPM planned home births, CPM-attended planned home births, for an aggregate rate of approximately 7.3 per 1,000 live births in North Carolina during the calendar years of 2011 and 2012, which is a factor of 5 lower than the 11 neonatal deaths in 300 CPM-attended home births claimed by the Medical Society. Looking at the population of singleton vertex CPM-attended planned home births, there was one neonatal demise and one intrapartum demise in the population of over 540 for a combined rate of 3.6 per 1,000 live births, which, while higher than the corresponding rate of 1.7 per 1,000 live births observed in the CPM 2000 study, is difficult to evaluate given the sample size and the information available for the birth events. The final point I will make is that during this time period, the CPMs had the lowest mortality rate of any class of midwife attending home births in North Carolina, and it is likely that several bad outcomes are being assigned to the CPMs by the Medical Society when the attendant was actually a certified nurse midwife or a traditional community midwife, as this makes for a better story to those who oppose planned home birth. If any conclusion should be drawn, it is simply that fundamental steps should be taken to cultivate a safe environment by licensing certified professional midwives, as Senate Bill 106 is designed to do. This discussion was deemed necessary in response to the outrageous and unprofessional behavior exhibited by the North Carolina Medical Society and sanctioned by their leadership. We did our best to be thoughtful, forthright, and complete in this response. It is sad to us that the Medical Society would intentionally and energetically do work to degrade safety of North Carolina families and to make false claims against certified professional midwives. Every honorable physician in our state should be outraged at how frivolously their leadership squandered their integrity, and it is our wish that those responsible will be held accountable for the greater good of the physician community and all North Carolina families, including those that choose the home setting for birth.